Good morning, ladies and gentlemen. Thank you for a nice introduction, and thank you for inviting me to speak in this Kuwait International Hemophilia Conference on the topic of guidance to the dental and surgical treatment of hemophilia patients case-based discussion. So I have nothing new to tell here. Hemophilia is as old as the hills. I will go with the one saying from the Benjamin who said, first I charge a retainer, then I charge a reminder, next I charge a refresher, then I charge a finisher. So to retain, everybody know, it's important thing is to play quiz test by giving some example and check your response yourself. It will retain for your whole life. Reminder, I will take you some guideline and practice. And third step, I will do refresher real world experience. What treatment algorithm we use in our scenario. And step 4 is finisher final take home message. So under the 40 to 60 minutes, the talk is guidance to the dental and surgical treatment patients. I will take you 6 steps. First is the eye opener, then basic A, B, C. A means assess the burden, B, basic hemostasis, and C, cause of bleeding. Third step, I will take you some quiz-based presentation, approach to coagulation disorder on physician on call. Then I will take you some guideline. And the fifth step, I will give you some challenge, how I treat in real world practice, and then final take home message. So this is the just eye opener. What color is the ribbon for bleeding disorder awareness? So color is red. When is the World Hemophilia Day is observed? It is March and April. Why March? March is disorder for bleeding and April is for hemophilia awareness. So this is third question. Why we are talking dental and surgical treatment of hemophilia patient? What is our object? The basic object is to understand the burden of the disease of hemophilia and bleeding during surgery, explore the barrier facing in achieving the accurate management of hemophilia and the surgery, and to make a correct in time referral and investigate and treat accordingly. So these are my objectives. Now, A, B, C. A means assess the burden of the bleeding encounter, who is at risk. Here is a big publication, prevalence of uncontrolled bleeding. It happens, you can see, in all subspecialties from internal medicine, general surgery, orthopedics, and emergency trauma, somewhere between 5 to 40%. So there is scope of this disease. B, basic hemostasis. Everybody know there are two hemostasis. One is primary hemostasis and secondary hemostasis. In primary hemostasis, actually, when an injury happens, there are two steps. First is the vasoconstriction, which limits the blood flow. And second is to pursue the more platelets to form the plaques, so they form platelets plaque. So this is the primary hemostasis. We are not talking of primary hemostasis. Today we are talking of secondary hemostasis, which occurs in a few minutes after the primary hemostasis. And this is the cascade of the coagulation that lead into the hard clot. Now, what is the cause of bleeding in this secondary hemostasis? We know hemophilia A and hemophilia B, factor 8 and factor 9. We know one Wolverine disease, we know factor 7 deficiency, and some acquired hemophilia. So these are the things actually we'll focus in our talk today. So after going A, B, C, I will go to step 3. So it's very important. Do this quiz-based question. Think in your mind and answer properly. Quiz 1. 18-year-old male just mentioned is confirmed hemophilia A. His factor VIII level is less than 1%. How should you label this patient hemophilia classified? This is the step one. How you label the patient less than 1%, very severe, severe, moderate, or mild. So you will label severe. Why it is important is the quiz one. Why is important? The level of factor 8 and 9 correlate with the bleeding. It's very important. We know severe hemophilia normally causes spontaneous bleeding and hemorrhage. And important thing is these patients, when are they are on factor level reception, so they develop inhibitors. So these are the important things. First step is to label how much severe hemophilia is. Second step, 18-year-old male, again, past state hemophilia, he come to you. So what question you usually ask about the anatomical location of the bleeding compared to primary hemostasis? You will ask, mucosal is more important, epistaxis, or joint bleeding. In primary hemophilia defects, most common bleeding is the mucosal and skin bleeding, which is often immediate. But in secondary hemostasis, which is often delayed, and it causes joint and muscle bleeding. Quiz 3. 19-year male hemophilia A level is less than 1%. He fell down and he sustained a large scrap on his forearm. He was profusely bleeding. He attempts to put pressure on it, but it didn't help. He's now starting to feel syncope, perisyncopal. He comes immediately to hospital and you are consulted. How much factor 8 should be given to this patient? Please choose. You will give 1, 5, 10, 30, or 50 units per kilo. What do you think? So you will give 50 units per kilo. Why? Patient has severe bleeding, not able to be controlled. It needs to be raised the level to make it normalize. So by giving this factor 50 units per kilo, you have to reach the factor level up to 100%. It's very important because patient is profusely bleeding. Now question 4. 19-year female, this is the female who has mild hemophilia. Its level is 15%. While playing basketball, she has feeling of early hemathosis. She's receiving 25 units per kilo to help the bleeding stop. What is the goal here in this case? Here you give 20, 25, or goal you make 50 or 100%. Previous case, we make it 100%. Here we have to make 50%. Why? Because it's mild hemophilia. And this is early hemathosis or minor hemorrhage. So here your target is to reach up to the 50% level, unlike the first quiz where I made it 100%. So it's very important to see the level, injury type, bleeding, very important. Quiz 5. 35-year-old male, hemophilia A, factor level is 4%. He has upcoming hemorrhoidal surgery. He went some complication during surgery as well. However, on day 3, they called you and they told you the patient has a lot of pains and conservative measures does not help. And he's currently, although not bleeding, because he's replacement of factor VIII. How should patient this be managed? Your target is to give factor VIII 100% level, 50% level, or just 10% level. Remember, this is major surgery. So what is your target? It should be 100%. Don't let drop below 50%. Give factor VIII level in any major surgery at 100%. Don't let it drop 50%. For surgery or major hemorrhage, don't drop 50%. Give enough factor initially to keep factor 100%, then you can reduce dose, but again, don't let drop to the 50%. So twice a day, you can keep continue like this. Now, number 6 question. 28-year-old male, factor VIII is 10%, presented to hematologist. with the mucosal bleeding, only mucosal bleeding after toothbrush. Otherwise, he's fine. He has no other bleeding. And the important thing is he has factor 8 is 10%. On presentation, minor bleeding in the oral cavity. Otherwise, joint is fine, no problem. He has no other side. What you will offer here? You will offer factor 8 1 to 50 or just aminocapric acid. This is a very interesting question. Think mild hemophilia and think mucosal bleeding. You will use aminocapric. Why? Because mild hemophilia and aminocapric is useful for mucosal bleeding, especially. The mucosal bleeding, for mucosal bleeding, this one every 6 hours. Even sometimes you can use DDAVP as well. However, if the even mild hemophilia has significant bleeding, then this will not work aminocapric. Remember, this is only for I'm telling you my mild hemophilia, minor bleeding. This is the different scenario. Please keep in mind. Question 7. 22-year male, hemophilia B, he came to ER. His history is he was playing tennis and he fell down and hit right knee. And his large hematoma is there. CT was done negative. Factor 9 was level 1%, but inhibitor level, which was done actually 6 months ago, it was 15. It's high. His current factor 9 and inhibitor is pending. You rush in the ER, you check the CBC is fine. So what therapy you would recommend? You will recommend factor 9. What do you recommend? Recommend factor 7, FFP, platelets. What do you recommend? Recommend factor 7. Why? Two reasons. Number one, patient has huge more than 5, if more than 5, these factor 9 will not work. And number two, even in this, you cannot use FIBA as well because that contains also factor 9 also. So it may develop further, inhibitors. And patient is large hematoma. So the only treatment here is recommend factor 7. Now, another question, 22-year male, severe hemophilia, less than 1%. He's on infusion. It used to take. Now he developed a spontaneous bleeding bilateral shoulder and knee. Although he's using factor 8, same which he's using before. What happened to him? Why he's not responding? So what test you would do in this case? You will check one brain factor 8 level or inhibitor level or DIC testing. What you will do? You will do inhibitor. This patient developed inhibitor. They need to be considered in the severe hemophilia that which doesn't respond to the infusion. As we know now, 30% patients of the severe hemophilia they develop inhibitor. So this is the reference in the blood 2009. In each quiz, I put reference as well. Question 9, 22-year who has factor 8 with inhibitor undergoes testing. It was 22 level. Which medication you will use in this patient? So similarly, here you use either FIBA or factor 7. You cannot use factor 8. So this is again bypass path. Now, question 10. 74-year who has history of lymphoma and diabetes, hypertension. He underwent some surgery. During surgery, what happened? He was profusely bleeding. You are called urgently and you find he has not any blood thinner. He's not taking any blood thinners. No heparin, no non-steroidal, no aspirin. His CBC platelet is unremarkable. What happened to him? PT is normal. Only thing is isolated APTT, which was high. So what you did, and you checked also his coagulation in vulnerable brain 6 months ago done because of easy bruising. It was normal. So now, which of the following is most likely etiology? Heparin, he has hemophilia A, B, or inhibitor. What he has? He has actually acquired hemophilia. Typically, middle-aged person who's bleeds. So this is two scenario of acquired hemophilia. Hopefully, you enjoyed the 10 quiz. And how much percent anybody take? 50%, 60%, 80%? Please, we'll discuss later. Let's move to the other part of my talk. Now, we are moving to step 4. In next 20 minutes, we'll talk about the guidelines and the treatment journey. Guidelines to dental and surgical treatment of hemophilia patient. As I mentioned in the quote, this is the reminder. So let's see what guidelines say. Surgical and dental procedure. Surgical procedure. Before 1960s, the mortality rate of hemophilia undergoing surgery was more than 50%. But as plasma and cryochem is decreased, and now most recent introduction of factor consultation, it is less than 1%. So major surgical procedure in patient coagulation disorder, particularly those with inhibitor, even cause risk and should be undertaken. Hemophilia care center is very important. Now, what is hemophilia treatment center? This is very important. Without hemophilia treatment center, it is unmet. You cannot treat the patient hemophilia without help of hemophilia treatment center. The solution is there. This is the missing part. You have whole treatment there, hematology, laboratory, social worker, dentist, nursing, internal medicine, all the things should be there. Then you can take the patient in the OR. Now, we know evolution of the hemophilia treatment has moved from FFP, then first to fourth generation of the recombinant factor 8, and then now currently we are moving to non-factor therapy. But what is the goal of hemophilia treatment? Good survival, minimal joint impairment, freedom from spontaneous bleeding, attain normal mobility, able to sustain minor trauma, and important thing, which is our topic, which I am talking since 20 minutes, undergoes a surgery or major trauma without additional intervention. So be careful going through all the steps and make it person normalized. We will discuss shortly. And with these goals, before we have short acting, now then extended hemophilia, then non-replacement therapy, then gene therapy is moving. So, currently we are using replacement therapy on demand, sometimes prophylaxis. We are using actually prophylaxis, both standard and extended we are using. And in some patients, we use also non-replacement therapy. But the most important thing is, please remember, there is significant variability of the clearance of factor 8. So each individual is different. So you have to patient plan before the patient in the OR. So how to tell us these things? So you need collaboration with the patient and family and, hematology center, which has access of a hemophilia care center, which I mentioned before, clear discussion, planning, checking PK and logging the tools and reassessment. So this is the guideline. Management of patient undergoing surgical procedure, before surgery, during surgery, after surgery. So pre-surgery, before surgery. If the risk of bleeding is very high, try to avoid elective surgery. Why? Because you have to check it. Screen for inhibitors should be performed. As I mentioned, 40% people have inhibitors. So it's important to check inhibitor level. Otherwise, patient will perfuse bleeding even you give factor 8 level. It's very important to make the patient plan before. Patient should avoid any blood thinner, any antiplatelet medication before and after surgery. Surgery should be scheduled early in the week and early in the day to ensure availability of the lab services and consultation, which I mentioned, hemophilia care center. Everything should be available. Adequate amount of replacement factor required before and after surgery should be available. Which factor? Factor 8, 9, 7, whatever, it should be available. And if available, pharmacokinetic analysis to determine the recovery and response to change the dose should be conducted before surgery. So this is all before surgery. And during surgery, explain the surgeon, caution, avoid medication or procedure that provoke the hemorrhage, any analgesic, anesthesia, or any cautery only for the capillary bleeding. Keep operation time to minimize. Use pressure bandage for soft tissue injuries. This is surgery part. Then patient recover from surgery and came back to you after surgery. What you will do? You have to careful monitoring factor activity level to maintain at least 30 to 50%, and in measures are up to 2 to 3 weeks. And remove suture after factor replacement given. This is clear guideline. Whole patient, you put all patient in the plan accordingly. Now, pre-hospital care, you have to explain, as I mentioned, proper discussion, the plan. And if patient come in emergency department, what you will do, you have to check type and severity of factor deficiency, nature of the hemorrhage, and planned procedure, previous treatment of the blood products which is taking, any inhibitors. So you have to check anytime it was given DDAVP with the degree of response, so you have to take history accordingly. So targets levels of hemorrhage severity are as follows: mild hemorrhage, like epistaxis, just maintain factor 8 30%. Major hemorrhage, in which bleeds with pain and swelling, or any other negative finding. So its target is 50%. But life-threatening bleeding like major trauma, surgery, or recurrent hematosis, your target is 80 to 90%, even 100%. After stabilization, maintain at the level of the 50% for minimum 7 to 10 days. So these keep in mind, and you can plan accordingly to patient's surgery ongoing. So this is another table, which is actually showing that before elective surgery plan, hematology should be consulted to arrange adequate coverage, as I mentioned. So there are four things are here: indication or site of bleeding, factor level desired, dose, and commit. Suppose patient has epistaxis, just epistaxis. You can use desired is 20 to 50%, and dose to 10 to 25 only. You can consider also, as we discussed in our one case as well, aminocapric acid as well. Then joint, your target is 40. Use this dose 20. So similarly, if you go differently, suppose knee, neck, and throat, your target is 80. And if you see go down trauma and bleeding surgery, your target is 100%. And it goes up to 10 to 14 days. So this graph is showing which type of bleeding, like hematuria, your target is 40, give 20 units per kilo, and then this is accordingly. So this is how the guidelines say, and you have to check the patient and you have to make it accordingly. So what is the minor surgery? Minor surgery means only which affects the mucous membrane, skin, and superficial connective tissue. Treatment is usually 2 to 4 days. But major surgery means any surgery other than the minor surgery. The treatment is at least 7 days, and it can go up to 21 days. So what major surgery person do in arthropathy? Sunectomy, arthrotomy, osteotomy, all these patients take 7 to 21 days of replacement. Most important thing, as I was discussing continuously, why inhibitor testing is important, because if you will, otherwise you will bleed, and you have to give, replacement factor, no 7 or FIBA accordingly. Now, is inhibitor is really high? What is the magnitude of the problem? Magnitude of the problem is high. It is because the people are using, on prophylactic factor VIII. Naturally, they develop inhibitor. So far now it reaches to 35%. It's very high. So this was very important. So now we are going step 5, second last step, real world experience. Let's do challenge. HIT means how I treat the patient. And this is called as a refresher of the real world practice. So this is a 31-year male who came from pediatric hematology to us about 15 years ago. And we saw him always, I show you the graph, always inhibitor high. So we give rituximab and ITI. Again, we give rituximab and ITI. Then, patient was continually on the FIBA. Now, this type of patient comes to surgery, what you will do, I tell you. This is the patient. In March 2019, the patient came in the ER. Severe abdomen pain and hemoglobin drops to 6. What happened? Patient has clinically symptoms of acute appendicitis. It was confirmed by the CT as well, and large hematoma is there. Not what we should do. At that time, you can say inhibitor level was also high, up to 70. So what we should do this patient actually, as patient was taking, fever on and off. So in this patient, we use actually, I ask you first question. So this is the big question of 2022. Patient with inhibitor already using FIBA. What we will do? One, immediate treatment, factor 7, or immediate factor 7 followed by FIBA. Use combine both. So in this patient, actually, we use factor 7, and you can say his hemoglobin improved. He underwent from surgery, he improved, and then he continuously, he continuously use factor 7, and it's went drop. And now again continue factor 7, again we start fever, again it went up. So again now we help him again for factor 7, he down. However, as you know, there is price problem, so naturally he is going to fever continuously, but now he's doing good. Factor inhibitor level is less than 5. So this is case 1. Now case 2, again 26-year male, known case of hemophilia. Again, the patient problem is what? Patient came with the left ankle swelling and bruise or the trauma. And this patient, actually, I show you the graph. He developed one time also inhibitor, and then he was in short-acting hemophilia factor. Then he was switched to the Electra, and on Electra he was doing good. And now again he was last to follow up, and then again came with the inhibitor. And actually this time he came with the swelling of the left arm, and this was the compartment syndrome. Now what we should do? Compartment syndrome, we consult the plastic surgeons, and they did actually left forearm physiectomy. And from the day 1 to continuously, here you can say no 7 factor was given about 2 weeks, and his factor 7, his inhibitor level also dropped, and now he's continuously taking successfully Electra as well. So this is also successful case. Here you see same case, inhibitor, second time inhibitor, third time inhibitor. This time actually he developed compartment syndrome, and with the success of the factor 7, with the help of this, he improved. Later he switched to the Electra, and he is doing great. Now, this is other case, factor 7 deficiency actually, other than the hemophilia A and B. Patient is a female, and she's going to labor. This is again planned. I told you, how we to plan. The baseline is, INR was 4. So what we give? We gave factor 7, 30 mcg per kilo, low dose here actually. And you can see after 1 hour we checked factor 7. INR dropped. You see, this is the green is factor 7 very low. So we don't check again and again factor 7, just give it. And the patient went for surgery. Then every 4 hours he was taking, she was taking factor 7, and she's doing great. So this is the plan, 30-year female. She was pregnant, ready for labor. So factor 7, 30 units per kilo prior to delivery. Then after was repeated every 3 hours, post-deliver at least 3 doses. So she went very well. Similarly, we have another lady, same during labor. Again, the baseline INR was this. We gave factor 7, it dropped, and she underwent all the plan. Then, she after 3 doses, she also went home. So these are the successful cases of real world. So 4 cases I presented. Now in next 3 minutes, as I mentioned, we go to 6th step. What was the 6th step? What is the goal and expectation of my talk? And then we finish it. So what is the goal and expectation we do? I can ask you the bonus question. Do you think I hurt the patient, or I hit the disease in all the scenarios? You have seen we hit the disease in all the patients. We managed properly, proper plan. So we did it accordingly. Now, take home. So the last 40 to 50 minutes under the guidance of dental and surgical treatment. We have seen the case-based discussion. We have gone through the eye opener. There have been day and everything. We have gone through the ABC, assess the burden of disease, basic hemostasis, and C, causing of bleeding. We have gone through the 10 quiz questions just to, reminder and recall the things. We have gone through the guideline, how the dental and surgical procedure should be done and what to remember. And the last, I went how I treat real world experience with bleeding management. And I show you the goal and expectation final text. So thank you very much. So this is my last slide. And if you any question, and we are happy to answer you whatever I presented during the quiz, any cross questioning, or the real world practice, or you have anything in mind, I'm happy to answer you. Thank you very much.